Hello, everyone. This is Dr. Ramesh Ayala from Tulane School of Medicine here in New Orleans, Louisiana. Welcome to our lecture on globe trauma presented by Meditrad and a leader in online training and education. Today, we're going to cover trauma related to the orbit, eyelid, and globe briefly, followed by a brief coverage of alkali and acid burns. I'm covering this as a introduction to these topics. By no means is this lecture a comprehensive lecture uh, uh, to give you full details as to how to repair and treat these patients. This lecture is more to be used as a guide towards further reading, and appropriate management techniques need to be learned from experienced faculty members because these topics and when you see patients involving this kind of trauma have to be taken seriously and treated appropriately. Orbital trauma, all patients with orbital trauma must have a complete ocular examination to rule out ocular trauma. Mid-facial fractures and orbital floor fractures are what we're going to concentrate on today. So how to approach a patient with open globe. First of all, you have to take a brief history. If you suspect open globe, call your senior resident, and this is for the sake of the first and second year residents, because in most residency programs, it's the junior resident who first encounters the patient with an open globe. Make sure that the patient had a tetanus, IV access, IV antibiotics, narcotics, and antiemetics. Call the OR or anesthesia staff to highlight the fact that the patient with an open globe is coming in. Protect the eye with a shield. Do not patch the eye. By patching the eye, you're going to exert more pressure on a globe that's already ruptured and open, and in the process may um, force the contents of the eye to come out. So as I said, when you examine these eyes with an open globe, apply no pressure. Suspect open globe when you see the following. Um, so when you see penetrating lid injury, when you see bullous subconjunctival hemorrhage, when you see corneoscleral laceration, when you see shallow chamber and a peaked pupil. Any one of these signs, if you see them, suspect open globe and tread carefully. So globe trauma, what to look for? You want to look for iris prolapse, hyphema, iris disinsertion, dislocated lens, vitreous hemorrhage, and when there's no red reflex, think of vitreous hemorrhage or detached retina. Let's move on to bone fractures. When you have significant trauma to the orbits, you can end up with orbital bone fractures, and you will be frequently called by the ENT and plastics and the ER guys to rule out orbital floor fractures and to do a complete eye examination. And this probably is the most common reason why an ophthalmology resident is called into the emergency room. So feel the orbital rim for discontinuity. If you suspect intraocular body, you want to order a CT, not an MRI, because these intraocular bodies could be magnetic. And by ordering an MRI, you're forcing the foreign body to come out in a disruptive fashion. The pictures that you see here are taken from the Iowa Ophthalmology University website. I hope they don't mind, as this is also a teaching site and essentially are showing various locations of orbital floor fractures with intraocular foreign body location. Here are some more pictures I borrowed from the University of Iowa, a wonderful website, and they do exhibit their extensive knowledge, especially this guy, Dr. Andrew um, Dion. He's got extensive write-ups on the University of Iowa Ophthalmology website. So I encourage everyone to visit it and go, and read the topics that they are covering in there. You can see a peaked pupil in this picture here, and the iris prolapse in the subconjunctival space in this location here. When you see this following trauma, suspect a penetrating injury. Here is a patient with iridodialysis. Um, uh, Here is a patient with what appears to be bullous conjunctival hemorrhage and soft eye. Um, Here's a patient with hyphema and could be a traumatic laceration in this direction. Here is an open globe through the conjunctiva and sclera that's picking up stain in that area. So careful examination is what is needed when you're dealing with these patients with suspected open globes. Do not apply any pressure while you're doing this. Gentle pressure. The patient, remember, is in severe pain um, because of the trauma, and you do not want to worsen the situation by applying more pressure on the eye. Um, in both situations, as the patient squeezes his eye as you try to open it, and if you apply pressure, the intraocular contents could come out through the site of the perforation. Uh, Once you suspect open globe, it's best to do the rest of the exam in rest of the exam in the operating room under general anesthesia. Uh, Looks like this particular patient here has a subluxated lens. You can see the dislocated lens, which is turned white, probably from trauma. Some more pictures of severe trauma. You can see a white traumatic cataract in this particular patient. You can see extensive lacerations involving the forehead. Um, uh, you can see another patient with a corneal lid laceration and open globe, um, and severe cases of motor vehicle accident involving the orbital floor fracture. So mid-facial fractures, or called the Lefort fractures, these are classified into three categories. The Lefort fractures must extend posteriorly through the pterygoid plates. The Lefort fracture type 1 involves a low transverse maxillary fracture above the teeth with no orbital involvement. Um, Lefort fracture 2 involves a pyramidal fracture involving the nasal, lacrimal, and maxillary bones and the medial orbital wall. And type 3 causes craniofacial disjunction and involves the orbital floor, medial, and lateral wall. This classification is useful for you to understand the severity of the orbital fractures and also frequently asked question in your board examination. Orbital floor fractures, pay attention to orbital floor fractures. Now, you should not miss if you see a patient. Also frequently tested in your boards. A direct fracture is extension from the inferior orbital rim. Indirect is not associated with the fracture of the orbital rim. It results from sudden increase in intraorbital pressure or orbital floor buckling from extension of compressive force extension from the orbital rim. These orbital floor fractures are frequently associated with lid ecchymosis and edema, diplopia with limitation of elevation or depression or both, anophthalmos, ptosis, hyposthesia in the distribution of inferior orbital nerve, emphysema of the orbit and eyelids. So look out for all of these signs, and when you see them, suspect orbital floor fracture. The treatment for the orbital floor fracture, if the patient happens to be an adult, initial observation for 7 to 10 days, oral antibiotics and steroids for 7 to 10 days to decrease the swelling, following which you can offer treatment, and we'll go through that in the next slide. Children with trapped inferior rectus muscle need urgent repair as it can cause bradycardia via the oculocardiac reflux. Remember this. So indications for surgery after the initial treatment in an adult to reduce the swelling and prevent infection. Persistent diplopia with limitation of up gaze or down gaze with positive traction test, plus a CT MRI evidence of trapped muscle 7 to 10 days post trauma is a number one indication for treatment. Also, patients with more than 2 millimeters of anophthalmos and large fractures involving greater than 50% of the orbital floor. All three of these are indications for taking the patient to the operating room and repairing the floor fractures. You should listen to our oculoplasty lectures by Dr. Dorai Raj um, for you to gain more knowledge in terms of the surgical techniques being used for the orbital floor fracture repair. So the treatment involves exploration, release of the muscle, and plate to prevent recurrent entrapment. Intraocular foreign body, wood or vegetable foreign bodies in the orbit should be removed. If it's a BB gun injury, it's best left without disturbance. MRI can be safely performed with a BB gun injury in the orbit. Loss of vision with clear media, look for afferent pupillary defect, which indicates optic nerve damage. In that situation, do a CT or MRI. Steroids can be used in the presence of traumatic optic neuropathy. The studies are variable. Most people conclude that if the optic nerve is severely damaged, it may not help. But if the optic nerve is just contused, then the steroids may be of some help. Loss of vision with clear media, check the intraocular pressure, afferent pupillary defect, tight orbit, and proptosis, suspect orbital hemorrhage. If this were to be the case, it needs emergent orbital decompression. So perform a lateral canthotomy and a superior inferior cantholysis. This procedure should be taught to every ophthalmologist and ophthalmology resident so they can take care of business in the emergency room um, uh, as soon as they recognize this. So if a patient presents to you with a tight orbit and proptosis and exhibits elevated intraocular pressure and an afferent pupillary defect, remember orbital hemorrhage, and that needs to be decompressed immediately. Blunt eyelid trauma presents to you with ecchymosis, needs complete eye examination, including dilated fundus examination. And to rule out orbital floor fractures, you want to perform a CT or an MRI. Penetrating trauma to the lids, lid laceration, and along with avulsion of the orbital fat indicates orbital septum being violated. Orbital fat prolapse in the upper lid wound. Levator should be explored and carefully repaired to avoid ptosis. Orbital septum laceration should not be sutured, close the skin and orbicularis. Um, Orbital septum incorporation into the wound can give you lag ophthalmos. So try not to incorporate the orbital septum for that reason. Eyelid margin lacerations, again, from the practical point of view, you need to know how to tackle this, and also they do pose some questions regarding this. Vertical matter suture to the margin along the meibomian gland orifice should be the initial suture that you want to place to get the anatomy right. Tarsal plate closure is to follow the vertical mattress lid margin suture. Vertical mattress suture to the margin anterior to the gray line is the place to apply. Skin and the muscles are closed after this. Canthal injuries, remember, results from horizontal traction, meaning that the lid is dragged this way or this way, which is where you have canthal injuries. Lateral canthal angle is sharp and medial canthal angle is slightly rounded. That's a normal appearance. A disturbance in this appearance is when you suspect canthal injuries. Rounding of the medial canthal tendon and acquired telecanthus um, indicates medial canthal tendon avulsion. If you are in doubt, always call your oculoplasty doctor to take care of these lacerations to help you out. But the important thing is for you to recognize lid lacerations, canthal injuries, orbital floor fractures, perform a complete eye examination along with them, and treat the patient appropriately. Let's move on to chemical injuries. This is a very important topic, not only to protect the vision of the patient in terms of immediate emergent management, but also from your exam point of view. Alkali burns result in worse injury compared to the acid burns. Remember that. Try to identify the offending agent if possible. Offending chemical may be in the form of a solid, liquid, powder, mist, or vapor. So the way the alkali burns work, they increase the pH, saponification of fatty acids in cell membrane and cellular disruption results on exposure to the alkali. Damage the surface epithelium leads to stromal penetration with damage to stromal matrix. The alkali can penetrate in severe cases into the antechamber, causing inflammation of the antechamber tissues and tissue damage. Whereas acid burn results in denature and precipitation of the protein, and as such, they cause less inflammation and tissue damage than alkali solutions. Buffering capacity of the tissue and precipitated protein barrier effect results in less inflammation and tissue damage compared to the alkali solutions. How do you grade the chemical burn? Grade 1, less than 50% of the corneal epithelium takes stain, minimal conjunctival involvement. Um, Grade 2. Now, I should add that you should follow the current grading system that is given in your BCSC book. The variety of grading of this chemical burns. This is one way where you look at the corneal epithelium and the conjunctival involvement. The more commonly used one, current one, deals with corneal haze along with the limbal ischemia. So in this particular grading technique, it's less than 50% of the corneal epithelium involvement with minimal conjunctival involvement, meaning that the limbal ischemia is absent. In grade 2, 50 to 75% epithelial damage uh, with with less than one third limbal ischemia. In grade 3, grade 2 plus, greater than 50% limbal damage or limbal ischemia. And in grade 3, there's a stromal haze to the point that details of the iris and the lens may be a little hazy, fuzzy. In grade 4, the 100% cornea conjunctival epithelial damage. The cornea is opaque, and greater than 50% limbal ischemia is associated with this. So the chemical burns because of limbal damage leads to stem cell death and conjunctivization of the cornea. So it's always important for you to look at the limbus and decide if there is associated stem cells while you're classifying these patients. Anterior chamber penetration of the chemical can lead to cataract and secondary glaucoma and iritis. In severe cases, you can see patients with the corneoscleral melt. So in terms of management, immediate and copious irrigation is the number one step. Remember this, both from the board's point of view and for practical treatment point of view, immediate and copious irrigation with whatever solution that you have to wash out the chemical out of the eye. It could be water, it could be BSS. If nothing is available, clean liquids that are there, such as a carbonated Coke can is use Coke. I mean, anything that you have that is clean, use that liquid to wash or dye. Continue the copious irrigation till the pH normalizes. Normal saline water, soda pop, any non-toxic and unpolluted liquid is okay. Topical anesthesia, lid speculum will help you to irrigate. Continuous saline drip or irrigating lid speculum um, is or should be available in most of the emergency rooms and can be used, especially in the presence of alkali burn, to wash out the alkali till the pH stabilizes. Then remove any particulate chemical, cotton tape or forceps under the slit lamp. Please make sure that you look under the lid. Now, once you've irrigated the eye copiously, pH is brought back to normal, and any particulate material that is there, especially under the lid, is taken out. The next step in the treatment would be to decrease inflammation and decrease PMN, the white cell function, and that's with the help of heavy dose of steroids every hour. Prednisolone would be an ideal choice here for the first 2 weeks. At the end of 2 weeks, you want to decrease the topical steroid usage. The reason why is to decrease the likelihood of stromal melt. And then consider using doxy or citric acid. These are chelators of extracellular calcium that decrease the cell membrane calcium and results in the white cell stability. Once the white cells become stable, they're less likely to release collagenolithic enzymes that can cause collagenolisis in stromal melt. Cycloplegic agents, both to decrease the pressure, to decrease the pain, and also to improve the, the pupil or decrease the risk of pupil from developing synovial adhesions should the patient have antechamber involvement. Topical antibiotics, of course, to decrease the risk of infection. I tend to use the Turbidex ointment, which acts both as a lubricant and has both a steroid and antibiotic, especially in mild, moderate cases. Vitamin C, 2 grams per day, help promote collagen synthesis in patients with severe alkali burns, something to be considered. Epithelial healing in patients with especially chemical burns with persistent epithelial defect or any epithelial defect right from the beginning. Aggressive management strategies should be employed to promote epithelial healing. And this includes frequent preservative-free artificial tears, bandage contact lens usage, tarsorrhaphy. Central tarsorrhaphy is a very useful technique in this kind of cases with persistent epithelial defect, amniotic membrane, either as a graft or as a contact lens, limbal stem cell transplantation after at least 2 weeks of trying the other techniques which are non-invasive. Lastly, should the cornea melt, you may consider an emergency cornea transplant. Prognosis is poor, and there's a role for keratoprosthesis, especially in severe chemical burns with and there are type 1 and type 2 Boston keratoprosthesis. Depending upon the severity of the burn, patients are selected to have type 1 or type 2. But the initial things that you can do include frequent use of preservative-free lubricants, the role of bandage contact lens to promote epithelial healing, and tarsorrhaphy. And nowadays, the free availability of amniotic membrane contact lens should be considered. All of these should be considered initially by you. If that doesn't work, obviously refer the patient to a specialist for consideration of limbal stem cell transplantation. And should that doesn't work, a PKP or a keratoprosthesis. Here is a patient with amniotic membrane graft in grade 2, 3 before and after. And as you can see, following the transplantation, amniotic membrane graft, the epithelium healed nicely. Here is another example of a patient with a grade 4 chemical burn. In following AMG, amniotic membrane graft, the epithelium healed nicely. So these pictures are taken from this paper published in Eye in 2003, Temporary Amniotic Membrane Patching for Acute Chemical Burns by Schaefer-Sang and his colleagues. Dr. Schaefer-Sang has done some remarkable work in this field and described the role of amniotic membrane grafts especially in chemical burns and Steven Johnson syndrome patients, something for every one of you to remember. I would strongly encourage you to follow the literature by Dr. Schaefer Sang in this regards. Here is the technique involved in application of amniotic membrane graft. The idea is to drape the entire um, um, uh, conjunctiva and cornea for limbus to from fornix to superior fornix to inferior fornix, and then twist it outwards to cover the inside of the lid as well, and then using matter sutures suture the amniotic membrane to the inside of the conjunctiva. And once that's done, um, and these are steps involved in various steps involved in this. What they're trying to do is to anchor it down to the limbus, anchor it down to the lids, and by the time you're done, you have the amniotic membrane covering the entire cornea, epithelium, the conjunctiva, and both the palpebral and the bulbar conjunctiva. And here is the detailed technique as to how this is done. A description of this is available in Schaefer Sang's classic paper on this topic. Um, uh, this is a fairly easy technique for most of you to do. A very useful technique, especially in the acute setting of severe chemical burns in Steven Johnson's patients. So that concludes the topic, the lecture for today. I thank you for listening to this lecture. Look out for more lectures on Meditread YouTube website, and look out for our upcoming CME and board review courses. As always, if should you have any comments, please send your comments to ayala@meditread.com or r@ayala@tulane.edu. Thank you for your attention.